After listening to the previous two talks, we would be looking at use of cyanoacrylate tissue adhesive and tenons patch graft in cases of if we encounter a corneal perforation in these microbial keratitis. So infectious keratitis is one of the commonest cause of uniocular blindness across the world. Every year an estimated 1.5 to 2 million people lose their vision as a consequence to microbial keratitis across the globe. Severe stromal thinning in cases of microbial keratitis can result in significant ocular morbidity, and recalcitrant cases can often result in corneal perforation. Such cases are considered as an ophthalmic emergency and may require urgent intervention to maintain the globe integrity. I'm sure every one of you must have faced this kind of situation in your clinical practice in your OPD. So failure to do so may result in catastrophic sequelae such as endophthalmitis, suprachoroidal hemorrhage, vision loss, or at times eye loss of an eye. The goal of treatment of corneal perforation is to restore the eyeball integrity and enable appropriate healing to occur so that a corneal transplantation or any other surgical procedure can be performed to regain the vision in those eyes. For a clinician to handle infectious keratitis is a challenge. Sometimes even if you are treating the infection and it is responding, they may end up into a corneal perforation. As you can see here, this patient sustained hair injury into the eye. The child was sitting in the lap of a patient and the hairs brushed against the cornea accidentally when they were traveling on a two-wheeler. As you can see here, this is not a very classical presentation, but you can see that multiple small infiltrates are there and there is a ring kind of an infiltrate occurring. On the first scrapings, we found out that there were gram-positive cocci, and we started treating this patient on antibacterial management. But as you see on follow-ups, this patient worsened further. So as Dr. Uma was alluding upon, many a times we may deal with more than one organism, and probably this was in addition to a bacteria, there were fungal elements also. So you have to add, so it is very important to even scrape these patients in between. You can see that now the patient has started responding to antifungal management, and this is how it responded, and eventually the patient healed with a corneal scar, but it does not happen every time. This is another patient where we found out that there was a fungal infection which started responding to antifungal management, but on the next follow-up you can see that the patient ended up with a corneal perforation. So what are the options for such situation when we see these patients like this on a follow-up? So we have various surgical options available. One is if the perforation is small, microperforation less than 2 millimeter or with a non-necrotic base, or you can go ahead and do a tissue adhesive application with a bandage contact lens application. One can also resort to a partial tarsorrhaphy when there is surface infection, persistent epithelial defect, or a non-healing kind of a defect. One can even use amniotic membrane grafts if there is a PED, or one can use a tenons patch graft if perforation size is more than 2 to 3 millimeter. If the size is, one can also even resort to conjunctival graft or a pedicle graft to bring in vascularization. If the perforation size is larger, one can do patch corneal graft, or at times they may require a tectonic therapeutic graft, or maybe at times more than a corneal graft, corneoscleral graft. So talking about the tissue adhesives, if the tissue adhesives are available in various, it could be synthetic, biological, or there are certain newer adhesives are also available, but commonest which is used in perforation is N-butyl 2 cyanoacrylate, which is a synthetic tissue adhesive. Biologicals, you all know, it is being used for sealing the tissue wounds, fibrin glue and all, and rest gelatin and thrombin, albumin, glutaraldehyde, and polyethylene glycol polymers are the newer ones. So what should be the properties of an ideal tissue adhesive? It should allow a sufficient working time before inducing a firm adhesion. It should have an adequate tensile strength to maintain the tissue or wound integrity. It should be biocompatible as well. It should be clear enough to permit vision, but at least cyanoacrylate is not clear enough. Permeable to fluids and metabolites to prevent necrosis, and it must not induce inflammation. Must disappear eventually to permit healing at the interface, and does not carry the risk of transferring an infectious agent. It should be accessible and affordable. So when cyanoacrylate was first discovered by Coover and colleagues in 1942 interestingly in a Kodak research lab. then in 1959 they reported unique adhesive property of this polymer and suggested its possible use for closure of surgical solutions, surgical incisions. Since then the application of cyanoacrylate adhesive has become the initial treatment of choice for severe corneal thinning and perforations as a temporizing measure to provide a tectonic strength to the affected corneal tissue. So how does it work? The esters of cyanoacrylate exist as a monomers in a viscous liquid state. Upon application, the monomers are exposed to anions from the tissue, which triggers the polymerization reaction, and thus it promotes a binding to the tissue. So when we apply the cyanoacrylate tissue adhesive, it should be, the base glues have been used most widely in ophthalmic surgery. They need minimal hydration time to polymerize. It provides tectonic support. The tensile strength of the bonding is very high. It can only be used externally because it induces a lot of inflammation if it goes inside the anterior chamber or it comes in contact with the iris. It is used as an off-label to seal the perforation smaller than 2 millimeter in size. It can also be used prior to definitive management like patch corneal graft. If you end up seeing a patient with a corneal perforation and you are taking that patient for a surgical intervention, maybe you can apply cyanoacrylate tissue adhesive on table to form the chamber, and then one can go ahead with a corneal graft. The major drawback is that they form a solid mass which is impermeable to the fluids and metabolites and will persist as foreign body, causing inflammatory reaction like GPC or at times corneal neovascularization. So it has to be covered with a bandage contact lens. So what are the steps of like tissue adhesive applications? Commonest available cyanoacrylate with us is acrylate. It is available in the form of small ampule. You can use it, you can fill up the syringe, a small 1 ml syringe with this glue, and you can apply a 26 gauge needle so that you form a very small amount of drop at the needle tip. It's important to assess the area of thinning or perforation, apply a local anesthetic drops, maybe proparacaine, dry the area, remove necrotic material with a sponge or a Johnson bud, apply a small quantity of glue and allow it to polymerize completely. If the area is small, one can use a 26 gauge needle, or even one can use the back of the sponge handle. Like you can just put a small amount of tissue adhesive on that area and you can just touch that area to the corneal perf site. This can, if it is a very small and micro perforation, you can even use it as in-office procedure. You can do this procedure on the slit lamp if the patient is a little cooperative. Finally, cover that area with a bandage contact lens once it polymerizes and continue antimicrobials as needed and assess the patient on a regular intervals. This is a surgical procedure to show how it is being applied. It is important to dry that area carefully, and you have to remove the epithelium to allow the glue to sit on that area and have firm adhesions with the underlying stroma. So carefully, gently, because this is a perforated corneal ulcer, so you are gently, it is important to remove gently the epithelium. So you can see that a 15 number sharp blade is used to just lift up the epithelium and let that area be a little rougher so that the tissue adhesive can sit there very well. I am using a 26 needle mounted on a 1 cc syringe, and a liquid glue is applied, a very small amount. You form a little drop there, take away an excess amount and then just touch that area to that perforation site, and it would make a small nice film over that area. If you need, you can additionally add some more glue to allow that area to kind of seal, and then once it polymerizes, you can put a bandage contact lens. This is similarly another case where instead of a 15 number blade, I am using a dry Marocell sponge. If it is dry, you can definitely remove the epithelium with the help of the sponge because it is firm, and that creates a base for your tissue glue to sit there, as you can see here. In a similar manner, you can go ahead and put a small amount of cyanoacrylate. As you can see here, a very small amount, and excess amount is absorbed with the help of a Marocell sponge. So a small nice thin layer is formed. If the tissue glue is applied in a large quantity, sometimes there would be spikes formed, or there would be very irregular surface, and if the patient loses bandage contact lens, they can have bleeding from the eye, or the upper lid would have, the upper tarsal conjunctiva would have papillary reaction. So as you can see here in these pictures, a very small amount of glue was applied. The tissue started healing, as you can see here. Can you see the mouse, or this mouse is not functioning? Sometimes once the cornea starts healing, as you can see in the picture on your extreme right and bottom, the cornea is almost healed. If the cornea heals very well, then sometimes the glue would get dislodged. As you can see here, that the glue has dislodged and it is lying onto the conjunctival surface. So bandage contact lens also has, been dislodged a little bit. So it can automatically also dislodge, or if you feel that the underlying corneal surface has healed very well, you can lift it up with the forceps and remove that on slit lamp as well. Sometimes if the perforation site is not very well covered, or at times it is loosely applied, you may require to have it more than one applications. But this would definitely invite a lot of vascularization, and it needs to be kept longer. Then we have to use, or we have to change the bandage contact lenses often. If the bandage contact lens is lost, patient may present with severe foreign body sensation and watering. So you have to explain that to patient beforehand. Too much glue up projection on the surface can lead to tarsal inflammation and papilla or bleeding, as I said earlier. If the base is necrotic, it can come off, and it may lead to a larger perforated area also. So those are the problems which we can face. So in this retrospective analysis, it was found out that the cyanoacrylate tissue adhesive was moderately effective in restoring globe integrity in severe corneal thinning and perforation secondary to microbial keratitis in the short term. However, the majority of the patients required tectonic surgical intervention within 6 months. So every time it may not be sufficient enough to take care of the perforation, but definitely you can use it as a temporizing measure, and eventually you can plan a definitive procedure later. And if you are just a comprehensive ophthalmologist and dealing with these kind of cases, maybe probably, and if you don't have a corneal setup, maybe you can refer these patients after applying the glue and having the globe tectonically stable. We'll come to the next surgical procedure, that is use of tenons patch graft. Where do we use, if the perforation size is larger than 2 mm, where you cannot use a tissue adhesive, and if it is mild to moderate perforation, either with or without an iris prolapse, one can definitely consider using a tenons patch graft. People were earlier using even conjunctival graft, Gunderson flap, and many other options were there, but tenons works very well. So what are the advantages? It is available in abundance, so no dependency on any other donor tissue. Tenons graft is harvested from the same eye, and hence obvious need for any storage. As it is autologous tissue, does not need any immunosuppression. Ideally can be used for perforations of 3 to 5 mm in size. However, it has been used for perforations as large as 6 mm also. There are reported case series about that. In presence of inflammation, the tissue may disintegrate faster, so it is not an ideal option to use in a very fulminant infection. The mechanism of action would be the tenons layer acts initially by plugging the area of perforation. The tissue provides a scaffold over which the surrounding epithelium would gradually migrate, and once the epithelial continuity is achieved, the wound becomes watertight, and the fibroblasts within the tenons layer may contribute towards the corneal scarring. Let's look at the surgical steps and the video. A small nick is made in the conjunctiva in the supranasal or supratemporal area, 2 mm behind the limbus, and the underlying tenons tissue is exposed. 1.5 to 2 mm is enough beyond the limbus, and then tenons tissue is dissected with conjunctival scissors. The size of the graft should always be at least 2 mm larger than the size of the perforation. Have a little larger amount of tissue than the size of the perforation. Any debris over the area of the perforation is cleaned. The excised graft is placed over the perforation and gently plugged into it. Either you can use a spatula or maybe a forceps or anything to plug it. I'll just take a minute to complete that.
Time Paras,
yeah, okay, fine. I use iris spatula, or at times you can use even a tying forceps, not a very sharp instrument. Once the tissue is plugged into the perforation, you can use either box sutures or an overlay tenno nylon sutures, which are applied in the pattern of infinity sign, where the suture should cross over the tenons area where you have plugged the tenons. In addition to that, one can even use a cyanoacrylate if it is needed, or if even I prefer to use a fibrin glue along with a tenons so that the tenons tissue remains bounded together. Post-operatively, one can use topical steroids and antimicrobial coverage till the infection gets covered. This is a small video of the procedure. As you can see here, there is a perforation with an iris prolapse. What we are trying to do is we are trying to harvest the tenons. I put a small incision into the conjunctiva and I have just taken out the tenons piece. Because there was, this perforation was sitting there for a little longer time, there was a little bit of, pseudocornea kind of a thing, which I have removed that epithelium. I have separated the synechiae with the help of iris spatula, and I am trying to stuff the tenons tissue into the perforation. Then I have applied both the components of fibrin glue so that the tenons tissue remains bounded together, and these are the infinity sutures with tenon nylon which you can apply externally to make sure that the crossing of the sutures is covering the area of the tenons material, so that the perforation site, so that it stays there and over that area very constantly, and that area heals completely eventually. These are the post-op pictures. Like as you can see here, the last picture on your right hand side shows that the tenons has become flatter. Initially it would become edematous and then it becomes compact, and you can see that the AC is very well formed and sutures are still in place. So this was about 2 to 3 millimeter size of perforation, and where we have reposited the iris, done a synecholysis, put in an air bubble and stuffed the tissue into the perforation, and I have used a fibrin glue along with. This is another example of a perforated corneal ulcer with iris incarceration, which was on treatment for a month. He was a tanker driver. He had some history of similar attacks almost a year back. So possibly this was a viral infection with a secondary bacterial involvement. We planned for possible tenons patch graft with tarsorrhaphy, but we thought that probably because in presence of a lot of infection and inflammation, I just continued with systemic antivirals and thought that let me do a tarsorrhaphy and see how this patient is behaving. Systemic and topical antivirals and antibacterials to cover the management part. And you see that in the follow-up, we can see that the area is showing clearance and the vessels are running in, the area has started showing healing, and this is how it started healing. So only a tarsorrhaphy also many a times can help in taking care of such ulcers. It's not necessary that every time we have to use a tissue adhesive or a tenons patch graft. Sometimes if this kind of presentation is there, even a tarsorrhaphy can help in healing these areas. This was another case, very interesting, like this patient presented like this with a large area of a corneal ulcer with a central perforation. You can see that the base is very necrotic. So this is not an ideal case for tissue adhesive as well as maybe probably a tenons patch graft. We just looked at the history and the other examination, and we realized that this patient had Hansen's disease, and that was missed initially, and probably that was the reason patient ended up with such a large ulcer. So because it was a very large ulcer, we had to do a therapeutic graft, but these are the cases where you have to add a tarsorrhaphy to that. If I would not have done a tarsorrhaphy, even this graft would have melted, because these are anesthetic corneas. So it is very important to recognize a systemic condition along with. This was another example of a case where there was a ring kind of infiltrate. This person was an agricultural person. He sustained an injury with a leaf, and we were able to just see some fungus onto the smears, but it was kind of unidentifiable fungus. It grew on the media as well. He was responding well, as you can see here in subsequent pictures, and we thought that he has really responded well, but eventually he ended up with a perforation. So it is very important to even taper your antifungals early on. If you just go on using your antifungals for a very long time, sometimes even toxicity of the antifungals also can lead to stromal melt, or at times even the toxicity of the organisms can lead to stromal melt. And these are the areas where you may not be able to apply a tissue adhesive for a very longer period of time. As you can see here, that there is a lot of necrosis around. So we went ahead and did a therapeutic graft for this patient. This was another young girl, 21-year-old young girl, who presented like this. She had a red eye and she was traveling, and she kept on using pyrimon eye drops, which is a common culprit, steroid and antibiotic combination, and she ended up with a large corneal ulcer and a perforation, and we saw her at this level, and we ended up with a doing a therapeutic graft for these kind of ulcers. So you know that which are the cases where we can do a tissue adhesive application and which are the cases where we can use a tenons graft. So the take home points from this is tissue adhesive and tenons tissue are easily available. They are inexpensive tools for small perforations and for stromal melts in indicated cases if used judiciously. It does not require much surgical expertise and can be added to the management armamentarium very comfortably by anyone. Can be used, TA can be done even as an in-office procedure if it is a very small microperforation, and can be used as a temporizing procedure before referring the patient for further management to higher centers. However, larger perforations may need management in the form of therapeutic or tectonic corneal or corneoscleral graft. Thank you for your kind attention.
Thank you very much, Dr. Paras, for that